Welcome. My name is Mario, and I'm the Global Senior Director for Artificial Intelligence working for GE Women's Health.
Hi, and I'm Heidi Harris, Global Product Marketing Director for MR.
So thank you for joining us for our second Beyond Breast Imaging webinar. This session will be focusing actually on how AI is changing the game for breast imaging across modalities. And it is part of the Intelligently Efficient webinar series. As you will see, we have some really top experts today. They're experts by experience. They're also opinion leaders. They're researchers. And they will be covering several topics around AI application in mammography, in other modalities, increasing diagnostic confidence in breast MR, benefits of using AI in breast ultrasound, etc. And we will also have a session that will be very interactive with them, very exciting panel Q&A, where we will have some questions we'll be asking them, and you will also be able to submit your questions for us to channel those to our experts afterwards. But before we start, I'd like to hand it over to my colleague Heidi for some pretty important information. Please pay attention.
Great, thanks, Mario. We want to take a few minutes to review some housekeeping tips and tricks. So you'll see at the bottom of your screen, there's multiple application widgets that you can use. All of these widgets are resizable and movable. You can expand the slide area or maximize it to full screen by clicking the arrows at the top right corner. There's a resource list also that you'll find some helpful materials that you can refer to after this webinar. And I'd like to point out the most important widgets on your screen, and that's the poll widget and the Q&A widget. We'll activate these polls between each presenter to get your feedback. And at any point during the webcast, you can enter your questions. And at the end of this talk, we'll be having a live Q&A session with the panel of experts. And lastly, an on-demand version of this webcast will be available for you in the next few days. You'll receive an email with the accessible link, so feel free to share it with your peers.
Apologies for that mute button. So thank you very much, Heidi. And with that, I want to give a little bit of context, just 3 slides to set the stage on what we're going to be talking about. The first one is what is deep learning, right? So deep learning is a subset within machine learning, and machine learning itself is a subset within the broader AI space. Now, what's really special about deep learning is that it uses very deep neural networks that allow it to learn very, very complex patterns. And these patterns are really crucial for some of the applications that we will be seeing in a moment, right? Now, this has been the primary driver of the recent progress with AI. Deep learning has really made a massive difference in the last few years. You can see here an example of the progression for computer vision. This is not in healthcare. This is for natural images from cameras, and it's already surpassed the human level performance since a few years ago, right? So it's very impressive progression, and it keeps getting better and better. Now, what about in healthcare? Well, first interesting data point on the left is that the adoption of AI in healthcare is really not that high compared to many other industries. Now, what's very interesting is on the right side, you can see that the investment in AI in healthcare is actually among the very top compared to other industries. So this is part of the reason that we are beginning to see a very strong adoption growth for AI in healthcare, and we will continue to see it in the next few years. Now, another point I wanted to share is, given what I presented a moment ago, you can imagine that AI is a top priority for GE Healthcare. And within AI for healthcare, breast AI is one of the absolute top priorities as well. And the reason is that there's many different application areas across the breast care pathway. Some of these you will see discussed with our great speakers in a moment, but they really range from risk prediction to some applications within detection and diagnosis, including exam acquisition for positioning, image processing, reading and decision support, all the way to the treatment of the patient, which are perhaps a little bit more longer term. Now, one example of this that is actually commercially available today is from our partner iCAD. They have this great solution called Profound AI 3D, where many of you may have already seen it or tried it. It has a very significant tangible impact on sensitivity and specificity improvements, which can be seen on the left and the right comparison here. So the left side are different radiologists, how they perform without Profound AI. The right side is with Profound AI supporting the radiologist during the reading. In addition to improving the sensitivity and the specificity, it also significantly improved the reading efficiency and the time to read. Okay, and then the final slide that I want to share is our precision health vision for breast imaging. And what you can see in here is essentially something that's very well known for the last decade or so. You can see how we went from FFD to DBT, 3D, and then more recently, more and more multimodality, including mammography, ultrasound, and MRI. Every step along the way improves the clinical accuracy, which is the vertical axis. Unfortunately, also every step decreases productivity, requires more time to read, more time to acquire, more efforts. So what we envision is that with AI, we will be significantly moving each of these bubbles to the upper part and towards the right side, meaning a substantial improvement in clinical accuracy, but also a substantial improvement in productivity. So that ultimately we expect to have an environment where we can offer solutions for multimodality breast imaging with AI and with a truly personalized screening plan. So with that, I'd like to hand it over to my colleague Heidi again for a couple of slides on MRI.
Great, thanks, Mario. And I want to share a little bit about what you can expect with AI and deep learning solutions when it comes to MR. So with MR, there's always trade-offs, trying to balance signal resolution and the time spent to get it. With AirRecon DL, we use deep learning algorithms and neural networks to train the system to learn what's good signal and what's noise, and then only reconstruct the good signal. The benefits? Pushing the scanner for thinner slices, higher spatial and temporal resolution, all while decreasing the patient's time on the table and without impacting image quality for all your critical breast MR scans. With GEMR, we're proud to continue the commitment of solving your daily challenges and innovative AI solutions. I'm going to bring it back to you, Mario, for the introductions.
Great, thank you very much, Heidi. And with that, we're really honored to introduce our three brilliant speakers today. First of all, we have Dr. Connie Lehman. She is Chief of Breast Imaging at Mass General Hospital in Boston, Massachusetts. She's also Professor of Radiology at Harvard Medical School. And she will be sharing with us her really exciting vision around AI across modalities to leverage the power of breast imaging. Then we'll have Dr. Vicente Martinez. He is head of the Diagnostic Imaging Service at Quirón Salud University Hospital and at Ruber Juan Bravo, based in Madrid, Spain. He will be sharing his great experience with AI for breast MRI. And last but not least, we have with us Dr. Kinda Duodari, who's an interventional breast radiologist, and he's also the head of the breast unit at the American Hospital in Dubai. She will be sharing her unique perspective and experience with AI for breast ultrasound. With that, I'd like to hand it over to Dr. Connie Lehman for the first presentation from our speakers. Connie, all yours.
Thanks so much, and I'm really just delighted to be here, and I'm especially looking forward to the conversation we can all have together. I love it that we have a global audience and experts from around the world. So there really has been an explosion of AI in the imaging space. no more so than in computer vision. Where will we take this? How will we leverage the tools of AI that have the ability to extract data from our images that our human eyes and our human brains simply cannot extract? We are seeing so many powerful tools in AI that are going to help us improve the outcomes for our patients. I'd like to start a little bit by giving some context in how I approach the explosion of opportunity with AI. And that's really starting with the problems that we face in imaging. There are 4 key problems that I think are at the foundation of where we are at the beginning of this revolution of AI. The first is the simple truth that most of the world does not have access to X-rays. This Atlantic article stated that one hospital in Boston has 126 radiologists and Liberia has 2. I know that's true because that hospital in Boston is Mass General, the hospital where I work. We have 126 radiologists and almost the same number of physicians that are in training at their advanced levels in residency and fellowship. So we have a lot of experts to read images. We also know that we are struggling with burnout. One of the key predictors of burnout is physicians that are saying, I went into medicine to help patients and to engage with people, and I am staring at computers for most of my day. We also face significant challenges in human variation and errors being made in medicine at large and radiology specifically, and in the domain of out-of-control costs, where we need to continue to push value and push quality, but contain cost. The imaging sciences and radiology is a key player. These problems aren't new. One of my favorite radiologists in our history is John Wolfe, who identified so many of our challenges early on. It was 1967 when he wrote the article describing the tedious task of examining 250 women to detect one cancer. This is not a great human task, and it's becoming even more complex and more challenging with tomosynthesis. Rather than 4 views on every patient, we literally have thousands of images to review for every mammogram exam. Now, if John Wolfe were to visit me at Mass General and come into our imaging clinic, he would recognize the mammograms. He would recognize how we're viewing them. He'd understand that we were looking at batches of screening exams from our patients. He would absolutely be impressed in the incredible advancements we've had in the technology to acquire better images, the digital technology, the advanced applications that we have in tomosynthesis. But he wouldn't notice significant differences in the paradigm for how we screen. Large batches of mammograms randomly presented to radiologists who sort through image after image after image in that search for cancers. But there are multiple applications of tools of AI in image interpretation where we can shift this paradigm, where we can go beyond traditional CAD, where the human is still reading large batches of images, but then processing flags and marks that are made on the image. We can look to a new paradigm where we could start to sort images, those that are more challenging from those that are easier to read, or even having a subset that could be analyzed by the computer alone. This pathway will be long. It will require radiologists and experts in the imaging sciences to really be steady guardians of how this pathway might happen. But I do think there could be a future where the paradigm has changed, where in very specific use cases, we can have computers really helping us get through large volumes of images. And this brings us to burnout. What we want to do is bring radiologists and bring doctors back to patients and away from the computer. And in an ironic way, perhaps, we can have AI bring us back to those human skills that we miss so much and allow AI to take care of those pieces in the computer that have really sapped so much of our energy and our time and attention. The third problem is human variation. 40% of US certified breast imaging radiologists perform outside the recommended ranges for acceptable false positive rates. So clearly we need to leverage the tools of AI to reduce human variation in interpretation. To date, we're actually pretty complacent about what we expect to see in expert breast imagers. as long as we're in a fairly wide range of 5 to 12% of recall rates, we think that that's acceptable. But what that means is you could have one healthcare center where radiologists are recalling 5% of patients to achieve the same cancer detection rate, and another center that has more than double that rate of recalls, which roughly translates to your rate of false positives. The same in the domain of cancer detection. Greater than 2.5 cancers per thousand is considered acceptable, but you could have a group of radiologists that are consistently finding 5 or 6 cancers out of every 1,000 women screened versus another radiologist that might be finding 2 to 3 cancers. And lastly, AI tools and how they can tackle the challenge that we have in value-based care. How can we deliver high quality at lower cost? One domain where this is so critical is in our false positive mammograms and our breast cancer overdiagnoses, which is estimated at over $4 billion a year in the US alone. I couldn't be more excited about the future with the AI tools. Clearly, humans will lead this revolution, and no one better, no group better than the imaging scientists, specialists, and radiologists to steer us in this pathway and in navigating through this revolution. I really appreciate your attention. I'm excited to listen to my colleagues' presentations and then to have an active discussion. Thank you.
Excellent. Thank you so much, Dr. Lehman. It's a very exciting vision. And with that, I'd like to hand it over to our next speaker, Dr. Martinez. All yours.
Hello, Mario. First of all, thank you for inviting me to this interesting webinar. And let's go. Breast MRI is based on the fact that after contrast injection, breast cancer enhances more and faster than normal fibroglandular tissue. It can provide us with 3 different types of information: the vascularization of the tumors, morphology information, and in addition, the diffusion sequences give us information about cellular density of the lesions. Morphologic analysis is important to increase the specificity of breast MRI, so margin in mass enhancement, abductal or segmental distribution in no mass enhancement are very important points to assess malignant lesions. Typically, breast invasive cancer appeared at MRI as masses with speculated or indistinct margins with irregular shape and heterogeneous or rim enhancement. Several publications have proved that invasive breast cancer can show well-defined margins in a variable percentage, from 5 to 30%. This wide range accounts for the variability in image resolution and tumor size, but using high spatial resolution sequences, less than 3% of malignant tumors showed well-defined margins. I'll show you an example of this. It was 2004, and this patient was studied with a dynamic breast MRI 3D fast PERT1 fat suppression with a spatial resolution 1.25 by 1.25. A small nodule, 5 millimeters in size, was seen in her left breast. The margin of this lesion looked well-defined, and the kinetic pattern was type 2 curve. By this time, we were testing Vibrant, a parallel imaging sequence that increased temporal and spatial resolution, and we repeat the exam 3 days later using this sequence with spatial resolution 0.8 by 0.6 and temporal resolution of 1 minute for bilateral acquisition. As you can see, the small nodule appeared totally different with microspeculated margins and rim enhancement consistent with malignancy. That was confirmed after MR-guided biopsy. So here you can see the importance of improving the spatial resolution. Let's go with the vascularization information. With the dynamic sequence, we analyzed the signal increase over time. Breast cancer typically enhances very fast during the first 2 minutes after contrast injection when the maximum peak is reached. Then, in the delayed phase of enhancement, there can be a plateau or a washout. The sensitivity of breast MRI is very high, almost 100% for invasive cancer, because vast majority of them enhance, but the problem is the variable specificity, because some cancers can show type 1 curve and some benign lesions can have type 2 or type 3 curves. From the beginning, our dream with MRI was to see better with more definition and see faster with reduced acquisition time. There always has been a struggle between temporal resolution and spatial resolution, but various advances have improved this relationship. 3D magnets with powerful gradients, new multi-channel surface coils, and different key space reconstruction strategies result in better signal-to-noise ratio and faster acquisition, allowing us to obtain higher spatial resolution images with very short acquisition times. The conventional dynamic MRI and Byrat's assessment focuses on the late phase of enhancement, which is easier to quantify. With conventional sequences, the early phase information is obscure. Important kinetic information in the early phase is occult. The question if it is important to improve temporal resolution. In some cases, especially in premenopausal women, the fibroglandular tissue enhancement, background parenchymal enhancement, can be very intense even in the first minute, and it's difficult to differentiate breast cancer from the overall enhancement of adjacent tissue. A strong background enhancement can lead to abnormal interpretation and inaccurate estimation of tumor size at preoperative stage in MRI, and has been associated with higher rates of positive resection margins. With this example, I want to show the importance of increasing the temporal resolution in cases where the background enhancement is strong. On the top, a large segmental enhancement of DCIS is observed in the upper quadrant of the breast. And with our conventional vibrant sequence 1 minute after contrast injection, it's difficult to discriminate the tumor margins from the background enhancement. We repeated the exam using vibrant with hypersense, reducing the acquisition times to 30 seconds and with the same spatial resolution. As can be seen in the bottom images, the tumor enhances faster than the fibroglandular tissue at 30 seconds, and the tumor margins are easier to demonstrate. But if the acquisition time is further reduced, we can get a new type of information. The strong and fast initial enhancement in breast cancer results from high vessel density and permeability caused by non-physiological angiogenesis. Ultra-fast dynamic MRI has been introduced to allow high temporal resolution without significant loss of spatial resolution, using different strategies of key space reconstruction, such as view sharing, disco or compressed sensing, hypersense, may make possible to perform ultra-fast dynamic MRI during the first minute after contrast injection. Initial enhancement was significantly earlier in breast cancer than in benign tumors. The main parameters for quantifying the initial phase of enhancement are the bolus arrival time, or time to enhance, and the maximum enhancement slope. The initial enhancement on the aorta is taken as a reference point to minimize the effects of various circulation time and the late contrast injection. The phase of enhancement was significantly shorter in breast cancer than in benign lesions, and according to this recent publication, there is a correlation with some breast cancer prognostic factors such as nuclear grade, HER2 positivity, or high Ki67. In addition, ultra-fast dynamic MRI has shown usefulness in characterizing non-mass enhancement lesions and can differentiate malignant from benign lesions. Non-mass enhancement is the major cause of false positive breast MRI findings, leading to unnecessary biopsy. These new sequences with different strategies in key space reconstruction allow implementing a hybrid protocol in the clinical routine that combines a multi-phase study with high temporal resolution, 6 seconds, and relatively good spatial resolution during the first minute after contrast injection, with a conventional high spatial multi-phase study starting from the first minute after contrast injection and up to 6 minutes to evaluate the late enhancement phase. Another advance with a major impact on MRI exams is AirRec-on-DL, which is a deep learning application designed to improve signal-to-noise and image sharpness, enabling shorter scan times. It uses trained neural networks to reconstruct the good signal and not the noise. AirRec-on-DL provides simply better image quality and productivity. In breast MR imaging, AirDL reconstruction is comparable with T1 and T2 sequences. In the top images obtained with AirDL, we observed higher quality, better resolution, and shorter acquisition time compared to our conventional sequence. There is an increased spatial resolution of about 45%. As a conclusion, I want to remark that new sequences with different key space reconstruction strategies allow us to acquire sequences with high temporal resolution and good spatial resolution, ultra-fast dynamic contrast enhanced MRI. Malignant breast lesions enhance earlier and strongly than benign lesions, and with ultra-fast dynamic MRI, this early enhancement can be quantified. The use of hybrid protocols in the clinical routine can increase the specificity of the technique, avoiding unnecessary biopsies. AirRec-on-DL provides excellent IQ and helps to drastically improve spatial resolution for anatomical T1 and T2 images. Thank you.
Great. Thank you, Dr. Martinez. And now we'll hand it over to Dr. Koldardi for her presentation.
A sort of early AI, which analyzes objects with, it does this object detection, object recognition. The deep learning is far much different. It doesn't deal with features. It doesn't deal with roles set by humans. It carries on its own very complicated analysis, combining all neural network, input layers, hidden and output layers. So CAD is easy. We know how to deal with it. We know how it works, so we know how to deal with it. Deep learning is more complicated. It's very performant. It can analyze patterns beyond the human recognition, but we don't know how it works. So there are a lot of applications or AI models using ultrasound, in ultrasound, and there were a lot of studies. Many models were analyzed. Actually, 2 models were FDA approved till now. It's the 3D one, the 3D ultrasound, and the KIOS, which is the 2D ultrasound. So the KIOS, this AI model in ultrasound is trained by a set of 450,000 images from different countries, different centers, different ultrasound machines, and it goes through this complicated processing, analyzing process. It can analyze up to 17,900 features. I don't even know what they are, all of them, but it can come out with a kind of estimation. It can say this is benign, this is malignant, with a very good accuracy rate, and it's very, very helpful in ultrasound. So it's not CAD. It's not an image detection, it's an image analysis. Actually, now it's deployed to the Logic E10, so it's easy to use, and it's aligned with BI-RADS category, so it gives this assessment of BI-RADS right away. So it's cleared as a second opinion. So when you work with it, it's as if you're asking a friend or you have a second pair of eyes. It's really interesting. So many studies to just analyze, like, the performance and all. And they all agree that it improves accuracy and that it can reduce this inter and intra-observer variability, which we always face with ultrasound and with all kind of imaging methods, actually. So I will show you some cases. For example, this is a kind of a nodule. This was a male with nodule, left breast. It's really suspicious, so we're going to do the biopsy anyway. So Kios gave, its opinion was like malignant, and it was, of course, invasive ductal cancer. So this is another nodule. It looks like benign. It's atypical, so biopsy just for confirmation or to rule out cellular fibroadenoma. So for Kios, it was most probably benign. So if you can see here, it gives benign. It's the BI-RADS, like it gives benign, probably malignant, and malignant, or suspicious, and then malignant. So sometimes it's surprisingly right, sometimes not. So this is what I'm trying to show you now. So this was a cellular fibroadenoma. Then this, for example, it was a nodule. For me, it was like BI-RADS 4C, BI-RADS 4B, but not less than that. For Kios, it was a kind of suspicious. And in biopsy, it was triple negative cancer, medullary thigh. So this is normally one of the lesions that it can go for, false negative. So this is why it can address this kind of problems. This is another nodule. It looks suspicious. For Kios, it was suspicious. Biopsy proves stromal fibrosis, actually. This was another nodule. For me, it looked atypical. I wanted to verify it by biopsy. Kios told me, no, it's benign. But I did the biopsy. It was stromal fibrosis, so actually it was benign. This is a very, very interesting case. This is a lady who had mastectomy. She had radiation therapy 3 years ago. I did the ultrasound 10 months ago. There was nothing, and then she comes in 10 months with this. So for me, because I know the clinical history, I was going for the biopsy for sure. For Kios, surprisingly, it gave me malignant. So this is something, like, I was very surprised because I can understand with CAD or with, a kind of, for me, I did the biopsy because of the clinical history, but yes, it didn't know the clinical history. So obviously it's analyzing features beyond our eye recognition or our human recognition. So it was, of course, an invasive cancer. It was a recurrence. So I believe, Kios, not Kios, the AI in ultrasound, it works amazingly. Sometimes it's wrong, sometimes it's right. So for the time being, we're in the primary phase. It's a kind of, it decreases the false negative. It can make up for experience and the skills deficiency on some beginners or some general radiologists who are doing breast or some, newcomers. It will improve, of course, accuracy and efficiency. We have to address some obstacles, for example, who's responsible for the diagnosis? I cannot follow it all the time, but I have to admit that sometimes it's surprisingly right. So, for example, once I had a cluster of cysts, and Kios gave me malignant. I was not going to biopsy it, and I didn't even save it into the PACS because, it can be. In the future, we will have these problems, because we don't know how it works, and I don't know if we ever will be able to know how it works. So this is what they call the black box problem. So for the time being, it works next to it's in tandem with a human radiologist to improve performance, but this is not all of it. Like it will not, I believe that with this extraordinary capability of analyzing features, it will not be only about benign and malignant. It will be able to do far much more than that. For example, it can be able to classify these, stromal fibrosis, sclerosing adenosis, inflammatory breast tissue disease that sometimes we're just confused with. It may be more performant with borderline classifications or BIRA 3 for AB, whatever. So to have less, positive predictive value. In addition, I can imagine that with this capability, it can, with another set of more complicated set of training cases, it can even predict tumor node metastasis, maybe treatment response. And if they came up with this algorithm to compare set of ultrasound, it will be an amazing add to our workflow. And again, if they will come up with this software which can combine modalities and also, this will be the future. I believe that this will be the future. And of course, by combining the ability of the machine with the ability of human radiologists, we can bring our ability to diagnose disease to the next level. Thank you.
Great. Thank you so much to our entire panel. So now let's move into the roundtable discussion, and then we'll have the Q&A to follow. We'll start with a few important questions. And meanwhile, you can start submitting your questions in the QA section down below.
Okay, excellent. So this is the most fun part of the webinar, right? The more interactive section. So we will have a few questions for the panel, and we will ask each of the three speakers, to give us their short answer perspective on this topic. The first one is, there are many AI tools being developed across multiple use cases, right? From workflow, interpretation, risk prediction, etc. Which of these use cases do you think can have the greatest potential and the greatest likelihood of being adopted short-term into clinical practice? Dr. Lehman, you want to go first? I'm not hearing Dr. Lehman. Maybe Dr. Martinez or Dr. Kinda?
Yes, for me, this is the most exciting part of AI. AI is going to be an indispensable aid in advancing many aspects of radiology. It will help to select which people to study and with which imaging techniques optimize the work of technographers, for example, facilitate faster studies with better resolution, and help us to post-process images and detect pathology, something like personalized radiology.
Excellent. Thank you so much, Dr. Martinez. Dr. Dodari, you may be on mute.
Okay. So I think that the most interesting part will be if we can combine modalities. This will be the great help of us radiologists. If there will be a combination of modalities, we're talking always about this multimodality perspective. So if we can have the AI helping us in achieving this, it will be amazing.
Yeah, agreed. Okay, and I think Dr. Lehman is still struggling with the connection. So let's maybe shift to the next question, and we'll go back to her in a moment. Heidi?
Yeah, I can see myself. I don't know if you can see me or hear me.
Oh, we can definitely hear you. So please.
Okay. Yeah, I agree with both of my colleagues. And very excited about the ability of AI to really change our paradigms across all three modalities. Mammography is going to be one of the most powerful just because of the sheer volume of exams that are present and the impact on the largest number of our patients.
Great,
Excellent.
thank you. Eileen?
Thank you. Yeah. So again, to the panel, maybe Dr. Lehman, we'll start with you. What do you believe is the top obstacle for wider adoption or full adoption, really, of AI across breast imaging?
Well, I think one of the real barriers is just change management. You know, that we have, we're all very, very, very busy. We're trying to see large numbers of patients, large volumes of exams, and the attention and time it takes to change workflow and to change processes is enormous in this domain. So I think we're going to need to really collectively, as a community of radiologists and healthcare organizations, really be shown the actual value. So we don't have time to play in these different domains. You know, we need to see which problems is this solving, where is the real value, and then we need to do that hard work and that heavy lift to make that transition for adoption.
Dr. Martinez, your thoughts?
Probably the conviction that AI is superior to us in the recognition and correct classification of lesions will be based in our own experience. The first step, I think, is to start with the screening studies, screening mammography, the application of AI with automatic breast ultrasound with ABUS will be also a potential field of fast development. I think that with breast MRI, AI will play an important role, initial as an assistant to the post-processing of different information of the images, the anatomical T1 and T2, the dynamic study after contrast, diffusion sequence, and we need to integrate all this information. The complexity is due not only to the large number of images obtained, but also the need to integrate these different types of information. But the fact is that it's more complex. It does not mean that it's not possible, but it will take more time probably.
Excellent. Dr. Koldardi, and anything to add on to that? Might be on mute.
Sorry again. So for me, again, I will go back to the that we don't have guidelines to use it. So we'll be using it more and more. And there will be, and as deep learning is something that we cannot understand, we will not be able to analyze or to, like with CAD, it's easy. We can decide when to go for it or not. We have, you know, we know what's going on. With the deep learning, we don't know. So we need just more structured information or like guidelines to know how to deal with it.
You know, I think that's a really good point that you raise, and I'm glad that you brought up the comparison to traditional CAD. When we try to transition through change, it often helps us when we can look back in history and say, when did we do something similar to this? And there are a lot of lessons learned, both on the positive and the negative side, from the application of CAD. So we still know that CAD isn't delivering on the promise that we originally had hoped for. And so in the area of AI, we have this second chance to really do it better. I'm seeing amazing rigor in how people are developing and training their models and testing and validating them internally. That area, I see a lot of people doing great work in, but we're not seeing that same level in external validation and what we mean by true external validation. And then we certainly haven't even begun to see what we think of as any level of real scientific rigor in studying carefully, once these tools are clinically implemented, how they are improving the outcomes of our patients. So we don't want to dampen the enthusiasm for AI. It's a revolution. It's changing the way we care for patients, but we really need to focus on real rigor and to separate out observations, anecdotes, exciting, cases where we discovered something that we hadn't seen before, but we can't have that fill the space. We're going to need to do a lot of work collectively to bring some real science to the assessment once these are clinically implemented.
True. Yeah, true.
Yeah.
Great points.
Thank you. Excellent points. And I mean, some groups are looking really deep also into explainability of deep learning algorithms, so that may be able to contribute perhaps to reduce to a certain degree the black box effect, right? Okay, so next question we have for you is perhaps a little bit more provocative. How far away do you think that we are from seeing some level of autonomous AI reading? Not necessarily reading all of it by itself, but AI being able to read some portion of the exams and maybe roll it out or whatever it would do with that. And also, for what type of indications do you think that may happen? Do you think it's somewhere in the horizon?
Maybe in screening.
So Dr. Godari, you want to start first?
Maybe in screening mammograms, like whenever there is a big mass of screening, this may be helpful. Just whenever it's virus 1 or 2, this will go by, it will be analyzed by the AI. And then whenever it's more than that, it will go to the radiologist. This will reflect, like it will just work well with our workflow, maybe.
Yeah, I agree with you.
Sorry, Dr. Lehman, please go ahead.
No, go ahead. So I guess you were asking the follow-up question of how long or how far?
Yeah, we're just wondering, like, how far away does she think it is?
How far away? It can be surprisingly short. It's like life is going very fast, so it may be in the coming 2-3 years. I don't know.
It is hard to believe. Dr. Lehman?
I agree with you, and I really like also how you present that this is a transition. It's not a light switch where we have reading rooms filled with radiologists reading mammograms, and months later they're all moved out and we replace them with robots. So, but it is a continued process of we have practices where they are double reading. There have 2 humans looking at every mammogram. So that makes sense that could be a first phase. How would it compare to have 2 humans versus an AI program targeted for that specific use case and 1 human? And then at the next level, just as you've said, would there be a subset that are so highly likely to be negative or without anything that a human would recall, that you could allow that to be a subset of screening cases with a very specific use that would be read by the AI algorithm alone? And we'll all remember, we have a lot of problems to address. So I know that sometimes we'll have radiologists that are fearful of being replaced. But we go back to the Liberia has 2 radiologists, Mass General has more than 126. So we need to think globally about where this fantastic modality of screening mammography that saves lives isn't being offered to most women in the world because of the absence of human readers.
True. Absolutely. Yeah.
Dr. Martinez, any thoughts from your side?
Yes, at this point, I agree with my colleagues, and I believe we are not far from beginning this path. Perhaps the first study to be reported autonomously will be the screening studies or the lesion follow-up. And that will be a good thing, I think, because the volume of imaging studies is increasing exponentially, and the number of radiologists is insufficient to deal with this demand. So we think we are beginning with this.
I also think, Mario, I'm glad that you're asking this question, because it's really up to all of us to decide what would be required for us to be comfortable to move to that domain. There are many people that just right out of the box will say, none of my patients would trust a machine. They want my eyes on their mammogram. Or radiologists that say, that would be, what a medical legal risk, that there be an obvious cancer and the computer would miss it. We would never, want to support that type of paradigm. And yet, we seem to be comfortable and complacent when we know we have humans that miss cancers, we aren't actually, if that's really our fear, then what are we doing to try to reduce those risks of human error? And are we using a different filter for determining whether or not it's, quote, safe for a computer to let a mammogram go through as negative versus a human to let a mammogram go through as negative? So just exactly what would be the power of the evidence that we collectively would be comfortable with to move into that paradigm? I think that's going to be the biggest predictor of, is it 2 years? Is it 3 years? Will it need to be 5? It won't be never. It's too important, and too many women in the world are depending upon this for us to not see this as a direction we can go in.
Absolutely.
Actually, I think it will depend on the generation. Like the old generation will prefer more radiologists. The new generation, oh, AI, it's just, it's so as mammograms is for more like older people, not older people. So it may take more time in this perspective.
I love it that you said that. I talk to my patients because we do have AI implemented in our center at Mass General. So I'll say, how do you feel about this? One of the things is fairly innocuous. It's an AI tool that assesses the woman's breast density and lets her know whether she's dense or not dense. But you're exactly right. My older patients will say, I just don't know if the computer cares about me the way you care about me. The younger patients are like, I don't trust humans. I want a computer to read my mammogram. I can't stand the idea that it'd be some random human that's tired, hasn't had their coffee, looking at my mammogram. So I think you're right. The generational change is going to be really interesting in the impact on our progression.
Great. Thank you.
Great thoughts, too. I'm going to switch to a few audience questions now. So, happy to guide this maybe to Dr. Lehman. Are you using any AI for mammography to predict risk of future cancers, or see any the progression towards that?
We are. So we have a model in place that, as I mentioned, assesses breast density, and that's something we trained, and we did a lot of research after clinical implementation, the acceptance by the radiologist, and the predictive capability. We also have running on every mammogram that we obtain, and we do about 50,000 mammograms a year in our Mass General system, future breast cancer risk scores. So a risk score at 1 year, 4 years, 5 years into the future. When we all needed to shut down our screening during the COVID highest level of crisis, we were then asked to bring back those patients at increased risk. And we actually used the risk scores we had from our AI model to rank patients that were higher to lower risk, and found it was the best method we had of finding those women at risk of breast cancer that had breast cancer. We hadn't thought to use it that way before, like who to invite back for screening, but it's really given us an opportunity to think carefully about what are different risk models, whether it's traditional risk models, genetic test, our AI models from the mammogram alone, how we can use them and where we can apply them. Because every risk model shouldn't be used for every question we have for our patients. But this is something that I'm going to go back to the scientific rigor in assessing the impact in the clinics. We've got a lot of work to do there, but we're pretty excited about it.
Great points. Anybody else from the panel care to add on? If not, that's okay. We can go to another audience question too. Okay, so the next question from the audience, what would you need to see to be convinced that AI-driven products can move from a research to a routine, or just that, continued development? So if you're coaching someone along, maybe Dr. Dardi, maybe you can take this one.
We need to trust it first. This is it. So we're in this phase, we're testing it, we need to trust it. The fact that these deep learning models can come out with some analysis that goes beyond our human recognition, and it can be surprisingly right. This is something that tells us that we have to trust it. But the fact that it's not performant every time, this is something that tell us, okay, we just need to wait a little bit. So I think we need time. The AI models need to be more trained with more sophisticated data sets. But it will be the future for sure.
Excellent, thank you. Probably just have time for just a few more here. Let's see here. Maybe AI for ABIS in the current and future state versus the traditional ultrasound role that's current. One of the sites here uses ABIS and is excited to hear about where that's actually going.
I used ABIS, actually. I used to use it, not anymore. It's interesting. It's time consuming. But it's interesting. So maybe with the AI models, whenever we are able to truly trust it, it will be of a great help, because the problem of ABIS is that it's time consuming. It's true that it's done by technologists, but the time that radiologists need to scroll through, and then if there is something to go for 2D ultrasound, this takes a lot of time. So if we can trust AI, if it's a powerful, like if we have a powerful AI to deal with ABIS, it will be a very good add.
Yeah, I totally agree with that. We also use ABIS. We're still using ABIS, and slightly in maybe a different application. It's in the diagnostic setting. We have centers where we don't have subspecialized radiologists on site, and there's, as you know, a lot of human variation with handheld ultrasound, and this allows our technologists to give us a 3D volume in an area of concern, either from the mammogram or the clinical exam. So we're very excited about ABIS, and every time I review a 3D ABIS exam, I think, what a fantastic opportunity for AI to help us with this, the different patterns and distinguishing normal from abnormal in a full 3D data set. So I think that application of AI and automatic 3D volume imaging with ultrasound is just ripe for exploration.
Great. Thank you.
Yes, I think I work with ABIS for screening patients with dense breast, and I agree that is a potential powerful field for AI in the next future.
Great. Yeah. And another question here, I'm going to guide this one to Dr. Martinez. With AirRecon DL, have you used it clinically or testings for breast MR, for abbreviated MR exams, or your thoughts on that?
Well, Recon DL is compatible on breast imaging only for T1 and T2 sequences, and these sequences are not determinant. You can reduce the time, but the most important sequences on breast MR are the dynamic sequence and diffusion, and AirRecon DL is not compatible with these sequences. However, we are using Recon DL for many applications in the rest of the body, and we can reduce time with very high resolution images, and it's a major advance in MR, I think.
Great. And, thinking about, the integration into PACS, or AI's integration into PACS, and sometimes it can be a little bit more challenging. And, we need this, the ability to be able to separate from mammo, MR, and ultrasound. Thoughts or ideas behind the works of, things that happen behind the scene to integrate that seamlessly into the PACS workflow? Maybe Dr. Colodardi, maybe you can try and tackle that one. Just looking at the PACS integration and workflow in there.
Yes, I think that the integration of ultrasound, mammography, and MR information will take some time. First, we are convinced that AI is working with every specialty, with every technique, and then will come the integration.
Great, thank you. Okay, and then just one last question here. You know, aside from the gold standard of prospective clinical data, what is the most compelling evidence to prove that AI will enhance diagnostic outcomes? Sorry, actually, let me take one other additional question here. How do you see CMS technology taking the place of mammography or in the mammography arena?
In the mammography? Can you repeat the question?
Oh, sure. How do we see, you know, the CEMS technology taking a place in the mammography arena, or in that mammography space?
Yeah, so the contrast-enhanced mammography to take mammography to the next level. And I suspect Heidi, that question may have been directed to Dr. Lehman, who has a lot of experience in contrast. Unfortunately, she had to leave. So I don't know if Dr. Martinez or Dr. Dodari, do you have some thoughts on that?
We started using the contrast-enhanced mammogram like 18 months ago, and it's very, very promising. It's very promising. So it has some limitations because of the contrast, but it's like when we don't have easy access to MRI, or as well MRI is very expensive, or it's the contrast enhanced mammogram will be the choice. And now with the new, like, we will receive like in 3 or 4 months the biopsy under contrast enhanced mammogram. This will be of great help instead of doing biopsies under MRIs, and we will just be able to do it here. This will change the way we work.
Great. Thank you. Anything to add, Dr. Martinez?
Yes, for me, contrast mammography could be great if you don't have access to MRI, because if you have access to MRI, you have more information, more anatomical information, more functional information through the dynamic exam during 6 minutes, and more functional information through the diffusion sequences. So if you don't have access to MRI, contrast mammography, it's perfect.
Okay, great. Thank you so much. Huge thank you to our special guests, Dr. Lehman, Dr. Martinez, and Dr. Dodari for joining us today. Big thank you to my colleague, Heidi, also to Anne Clement, who has been working with all of us to make this possible. As a reminder, an on-demand version of this webcast will be available to you shortly. You should receive an email with the link to access it. This now concludes our webinar, and I would like to turn it over to Anne Clement, who's our Director of Global Marketing Communications. She has some final remarks to share regarding some next webinars that are on the agenda for later in the year. Anne?
Great, thanks, Mario. And thanks everyone for joining, and especially to our panelists who were absolutely outstanding. Just a few things for those who are still on. So we will be observing International Women's Day with a virtual event March 8th. So please stay tuned for more information on gehealthcare.com on how to register to join some of those presentations. Furthermore, we will have more Beyond Breast Imaging webinar events that will be held June 4th at 7 o'clock Central European Time or 1 p.m. Eastern Standard Time. We will have another one September 14th and November 16th as well. So we will give you more information on that detail. And then furthermore, if you'd like to see some of our previous webinars, please go ahead and use your phone to scan the QR code, and you can access that information. Finally, just again, want to thank everyone, and we'll leave you with one last poll question to help us make sure that we're getting all of the webinar content that you'd like. So just, you can keep this in mind for, some interesting feedback for when we write out to you again and we have the next session. So again, thanks again, everyone, for joining, and have a great afternoon, evening. And we'll speak again soon.
Great. Thanks, everyone.